Hey guys, this is Cedric Spock, clinical infectious disease. In my previous career, I was a clinical virologist. This is COVID-19 talk, March 24th, 2020, sort of uncut and uncensored, asking questions and thinking about how things are moving forward. I'm not an official. I am a clinician. I'm talking to other clinicians. We are just trying to share information because we know that when we talk about infectious diseases, the best way to manage infectious diseases is with knowledge. Last time we gave this talk was a week ago. We've learned a lot in the last week. So one of the things I'm learning is how to move forward as we all worry about something we've never worried about before. We are all worried about getting COVID-19. And so there are lots of questions about what's the best way to protect us and how do we protect each other and how do we protect our patients? And there's an ongoing discussion, local, citywide, nationwide, hospital-wide. Mass General, for example, on Sunday announced that all employees have to wear surgical masks. And they also issued a video on how to conserve N95 masks. I'm wearing an N95 mask. So, for example, what they said was that if you're going to do what's referred to as extended wear with your N95 mask, then they suggest that if you remove the mask, that you actually place gloves so that your hands, which may or may not have been contaminated because we are still trying to figure out this infectious disease, and then we take the mask off, and then we don't touch the face. And then let's say I'm trying to take a break because I have to go eat a sandwich. I put the mask off to the side, and I'm actually setting it on a conveniently placed alcohol swab right next to the keyboard. And then I take my gloves off like we always do, and then of course we have to discard them. Germ theory of disease is what we're talking about here. There are now editorials in major publications like the New Yorker, Forbes, New York Times, Wall Street Journal about how nurses and doctors and other of our colleagues in a healthcare setting are nervous. And we're nervous because of this uncertainty. History might help because a lot of times when an infectious disease happens, we have to learn the science at the same time that we're taking care of the infectious disease. Infectious diseases physicians remember this quite well. We've been through several different epidemics. When I was a medical student, we were in the midst of the HIV pandemic, and it was referred to as a pandemic, but it was very different. And during the beginning days of the HIV pandemic, there were many, many questions of what could or couldn't be used, how could these patients be taken care of, and there was a several-year period of hopelessness, and then finally, scientific innovation, clinical trials, and then effective antiretroviral therapy, namely sequinavir, really kind of changed the landscape. The first few medications which were tried for HIV were not effective. Then they learned additional medications which are marginally effective. I thought about this second lecture, recognizing that a lot of the listeners don't remember those days. Back in the early 1980s, professionals were showing up in doctors' offices, weight loss, chronic diarrhea, thrush, laboratory studies showed malnutrition. There was no obvious explanation. Different descriptions were happening prior to social media. It was referred to initially as gay wasting, and then it was referred to as slim disease in Africa. When it finally got characterized as an infectious disease, it was actually controversial. Coming up with the test was difficult. The first test was the Western blot. It was time-consuming and laborious. There were times where the Western blot could not be done. Clinicians in the trenches sometimes had to deal with patients who, because of legal reasons, couldn't be tested. So there was a political aspect for taking care of HIV patients. At Parkland, for example, when I was an intern, there was a piece of paper that had to be signed in quadruplicate with the consent so that the patient would actually agree to HIV testing. Imagine how you would have to feel as an intern is if the man comes in, or a woman or patient or whatever, and they have thrush, wasting, diarrhea, anemia, infiltrates on their lungs, you're recognizing all these clinical syndromes, the patient refuses HIV testing, and you have to act anyway. Quickly, clinicians talk to other clinicians. they started realizing ways to make rapid diagnostics in the absence of invasive diagnostics. Pneumocystis, for example. Initially, it was thought, all right, we have to get a bronchoscopy. But bronchoscopy back in the 1990s was a rigid bronchoscopy and required something that had to be done in the operating room. Flexible bronchoscopy wasn't really available and was just starting. Testing and clinical assessment. I realized myself as an HIV physician that this is the way the infectious disease physician can help the rest of the medical community. We are familiar with these kinds of issues that have happened, and we also are familiar with the uncertainty. So with this in mind, we have to then communicate with each other frequently. And that was kind of the hope of these lectures, which will be maybe on a weekly basis, because I'm getting more questions. We're all getting questions. We all check New England Journal, social media, we go to different journals, we talk to our friends at other hospitals, we hear different stories. So for example, we know that some hospitals have much more COVID-19 patients than our hospital does. We're still wondering how many patients have COVID-19 in our hospital. You know, there are town hall meetings at our hospital that are probably similar to town hall meetings at other hospitals. So when it comes to diagnostics and recognizing the burden of disease, the concern is that the burden of the disease will soon become very great. So that means we are in this together. As far as the fear and the fear of disease acquisition, I think that is real, and we need to move forward and try and figure out intelligent ways. I'm seeing a variety of things on social media. Nothing is really being socially validated. For example, Stanford Medical School actually sent out a document that if you took your N95 mask and brought it home and put it in the oven at 165 degrees Fahrenheit for 30 minutes, that will preserve the N95 mask and kill all the microbes. That's great. It's not a randomized controlled study. It hasn't been validated by the federal authorities. Makes me wonder, is that something that's going to become the standard? Are we going to reuse our 95 masks? I don't know yet. We'll have to wait and see. Other questions that are being brought up. What about therapeutics? There are therapeutic interventions. What about diagnostics? Why don't we have diagnostics yet? Well, diagnostics are complicated and they are rolling them out, and we will have better diagnostics. And there is a hope that as each week goes by, diagnostics will be improved. I encourage everybody, be patient. Don't be ugly at the hospital or at the lab or at the COVID hotline, because we're all figuring this out together. The diagnostic is unfortunately right now a precious resource. We can't test everybody, regardless of the public health thoughts that this would be beneficial. So we're trying to test those who are appropriate. It seems like almost every day the testing changes. The recommendations, we need to rule them out. How do we rule them out? Once? Is it now twice? Stay tuned and keep an open mind, remembering that this is a changing field. Therapeutic questions are coming up. You know, just last week, the president of our country said that Plaquenil, he had a good feeling about it. And as a result, there is no Plaquenil to be found anywhere right now. And there is a clinical trial being administered by the University of Minnesota for any healthcare provider who is exposed to COVID-19. And you can look them up, University of Minnesota, on Google, and you can send an email. And if you're a healthcare provider and you think you're exposed, you can send them an email, and within 24 hours, they will FedEx Plaquenil versus placebo, and then follow you via a digital clinical reporting form. This is novel. This is outstanding. We're getting clinical information. So that's something that we can share with each other. If I get exposed, and I think I was exposed, I know somebody had a positive test, what do? I encourage you to contact the University of Minnesota. They have a nice website, and it seems like it's ready to go. And last I heard was yesterday, is they are ready to enroll 15,000 healthcare providers across the country, and there's really no strings attached. And I've heard from several healthcare providers that they received the Plaquenil or placebo within 24 hours, FedEx as described. Other therapeutic issues. There's been a lot of interest in the idea of Plaquenil plus azithromycin. It is becoming a sort of protocolized approach within hospital systems. The hospital systems protocols are being shared widely. All of us have colleagues at other major medical institutions. There is no need to reinvent the wheel. as these are being shared with each other, we are realizing that we're all recommending similar approaches. It's thought that Plaquenil plus azithromycin might help. It's being attributed to what's called the French study. The French study, actually, as of now, has not really been validated with large randomized controlled trials. So the French study is all we got. Well, we had similar things with HIV. When we first learned that steroids were helpful with pneumocystis, it was based on one ward experience at Mass General, where they showed that less than a dozen patients who got prednisone before the initiation of Bactrim didn't die. That was the trial. It wasn't good, robust, randomized controlled data. So I get questions every day. Hey, Spock, what do you think about Plaquenil plus azithromycin? The honest answer is I don't know. It might help. Unfortunately, we don't have a lot of Plaquenil, and unfortunately, we probably aren't going to have a lot of azithromycin, but we probably are going to use it. And is it going to harm our patients? Well, the official recommendation is check a QT, make sure you're not prolonging their QT interval, because both of these drugs may have some effect on QT. Other therapeutics are being looked at. There is a clinical trial going on at Baylor University Medical Center and at Baylor All Saints and at Baylor Scott and White Temple using the Gilead drug remdesivir. And it is looking at patients who have moderate disease or severe disease. And really all you have to remember is 94%. And so the trial is enrolling now, and patients are getting enrolled at all 3 medical centers. This is good. We need clinical data. As far as other issues, the patients themselves. The patients aren't going to come in with a label of I have COVID-19. And so last week, discussing, all right, what kind of clinical presentations are they going to have? Are they going to have these standard things? And it still seems like what we learned a week ago still holds. Normal procalcitonin, low lymphocyte counts, very high fever, pulmonary infiltrates, respiratory complaints. Respiratory complaints typically not associated with dyspnea, so they may have a hypoxemia out of proportion. Not everybody gets so sick. We still aren't sure what percentage of the population is asymptomatic. We also aren't sure what percentage of the patient population that gets symptomatic, who we need to risk stratify, but it does appear that those over the age of 80 are at greatest risk. Management. I'm seeing all sorts of good things at the hospital. People are talking about the management of this disease. Once the patients are here, how do we move forward? How do we intubate the patients? We're going to have to be creative. How do we minimize aerosolization of the actual viral particles? So there have been thoughts of using clear trash bags, which has been looked at several medical centers. There's been thoughts of using other sort of fiber optic issues. And I am not an intubation expert. I work with a lot of doctors who are intubation experts, but this is something that is also brought up. Emergency room physicians, hospital physicians, ICU physicians are all thinking about what does this mean. As far as the actual protection, the mask I took off, N95, there is a shortage of N95 masks. It does seem to confer a benefit. The degree of benefit is still debated. Whether or not it's safe to wear the mask all day is still not known. We may have to change our practices based on further data. Am I getting questions yet? No, no questions yet. Okay. So that's kind of my, I guess, opening statement. I can't really provide a lot more information yet. I can tell you that information on the internet is widely available. It does seem to be that there are some confusing data. Some of the data isn't necessarily useful. Myself, I have found very helpful JAMA Network. They have a daily YouTube interview with a variety of very, very thoughtful experts in the field, including Dr. Tony Fauci. So I have been listening to these on my drive to work and my drive home so that I can kind of hear what they have to say as they're learning about it, just like we're learning about it. The New England Journal is updating every day its COVID-19 resources. And then other journals are also trying to do the same thing, including the Annals of Internal Medicine and JAMA itself. So I think we are going to be able to get that information. And I think over the next few weeks, we will all become COVID-19 experts, similar to back in the 1990s when every single clinician in the hospital became an HIV expert. Imagine that when I was an intern back in 1999, we never called anybody for help with HIV because we all had HIV patients on our service and we all became very familiar with it. And I'm not telling you don't call specialists for help, but I think we need to recognize that we're going to learn a lot and we are going to become very skilled at this because we've been taught to learn clinical medicine, we've been taught to practice, we've been taught to think. And as we learn this, we're going to then talk to each other and share our experiences and share our data. So, other questions that were brought up to me. I'm going to look over in my little audience here. What else do I need to say? Dr. Weddle? Anything that you're thinking of?
I guess my question is knowing how many asymptomatic, I mean, obviously we have no idea how many asymptomatic are out there. Do you have any thought or feeling on how widely testing may become or timeline on that?
So the timeline is on testing and defining asymptomatics, which is actually a very important public health question from an epidemiology standpoint, looking at a disease state that is actually very different from HIV. Because HIV, there was an asymptomatic phase, but typically patients succumb to the disease at a different time course. And so testing and then treating patients made a lot of sense. In the natural history of this disease, there are individuals who acquire the infection and do not become sick. There are also individuals who acquire the infection and then recover. And the level of recovery is still under discussion. There are reports now that some individuals that they thought were asymptomatic afterwards actually have a persistent anosmia and are unable to smell. I don't know what the percentage is. In South Korea, they have rolled out widespread testing and are better at defining all the asymptomatics. We right now are really not even able to estimate a percentage of how many in this country are infected. The other thing that we are unable to estimate is who has been infected and is no longer infected. In other words, what tools do we need to show that somebody had already been exposed? We're working on that. Coronaviruses are known to clinical virologists. Other coronaviruses clinically behave like rhinoviruses, and rhinoviruses cause upper respiratory tract infections, quote unquote, the common cold. Long-term immunity to rhinoviruses has not been described. Coronaviruses, less well understood. We also do not know if long-term immunity has been described. That could be potentially worrisome. And so we don't know to what extent this coronavirus will behave like other coronaviruses. Obviously, there's an explosion of research into all of these different questions. Different medical centers across the world are trying to look at it from both a basic science as well as clinical. As far as the rollout of testing, the hope is that within the next 2 to 4 weeks, we will have more readily available testing across different hospital systems. There also is a hope that we will be able to target testing to those that we think are at greater risk or have clinical symptoms. We do not know when we will be able to provide clinical testing to asymptomatic as an epidemiologic tool. We also do not know if we will be able to provide serologic testing on a widespread basis yet. So I'm worried about that, but I also have to remind myself that it's been like this with other infectious diseases. And so I'm trying to keep an open mind and be clinical and say, all right, every week we're going to learn something new. Let's see, am I getting questions yet on the chat? Doesn't look like it. I don't know if anybody else in any of the other rooms have any other questions that I might be able to help with. Last time I got a bunch of chat questions. This time I'm getting none. No questions. None.
Can everyone see? I can't see the chat option.
You can't see the questions?
We can't see the chat feature.
Yeah, there's a chat feature.
What about
Go ahead and ask
those
questions.
patients that get tested twice? What's the risk of a third test coming back positive?
Oh, so question is if you have if you have two tests, can you get another test that turns positive? Really, we have two issues. One is we need to have adequate methodology for sufficient nasopharyngeal swab. Many hospitals, this one included, are now coming up with a sort of a swab team. I think they actually called, what did they, I think they called it swab team, or was it swab team? Yeah. And so swab team is what we need. And so basically you have an operator who becomes so experienced at doing the appropriate nasopharyngeal swab that will increase the yield of the patient sample. Getting a second sample and then it's negative should provide reassurance, but recognizing that we're still trying to learn the disease, what if the person under investigation could still have the disease after that? Could you have a third sample that turns positive? I imagine so. I also imagine that we're possibly going to have person-to-person transmission at a variety of settings. H1N1 did this back in 2010. We saw person-to-person transmission within the hospital setting after patients were initially negative. It looks like I am getting questions now. So, let's see.
The new messages at the bottom right.
New messages. There we go. There we go. So the next question is, what about patients presenting with GI symptoms? So there are additional reports of GI symptoms as being potentially descriptive of this disease. And we're not sure what to make of that yet. I guess you could say if they have GI symptoms and you check them for the usual suspects and everything's negative, then they may have COVID-19. There's also been a suggestion that those who have GI symptoms may actually be resolving or responding to this quicker. I think if anybody else is having trouble with the messages, you could also send me a text if that helps. So, all right, looks like some people are trying to chat. If you just want to send me other questions.
What do you think about the sputum induced, having the patient induce sputum on their own?
So that's a very good question, because in other countries, they're looking at that. And in fact, in South Korea, they have created a Korean language video telling patients how to provide their own respiratory sample. Now, from a lab medicine standpoint, excuse me, they will be very particular and say it's not really sputum. It's actually a nasopharyngeal swab. Sputa in and of itself will be more of a lower respiratory sample, and there's some technical differences between that and a nasopharyngeal swab. And as it stands right now, a nasopharyngeal swab is really the ultimate and best test to perform on these cases. Another question popped up. Okay, great. New message. So I have to click new messages. Okay, there we go. All right, yeah. So something else that gets brought up is, what do you do when you hear about an exposure? And then to what extent is the exposure at risk for patients or for yourself? So if you hear that somebody was exposed, maybe turned positive, you had seen that somebody, where are we in this setting? How much at risk are we all going to be? Those are tough, because I get those questions every day. And they're a lot of times in unexpected ways. I've been asked, what if I know of somebody at school who turned positive and then they already went home? I hadn't seen that individual in 7 days. Am I at risk? I can't answer that question yet. All right. Looks like we don't have as many questions last time, so this might be a shorter presentation. That's the team here in the room. Any other questions y'all can think of? No? All right, well then we'll cut this short at 30 minutes. I guess it's good. Get ready. We don't know how bad it's going to be over the next week. We're obviously preparing. Thank you guys for your attention. And then if this is helpful, we can do it again next week or at any other time that's suitable to you folks. And thank you for your attention and good luck with your day.